Good evening, everyone. It's me, Quratulain, a clinical psychologist and personal therapist. Currently, we have been working on our clinical course of treatment management in psychopathology. We had discussed about the bipolar and related disorder in our previous lecture, and today we will be continuing this chapter, and we will be talking about substance and medication-induced disorder regarding bipolar disorders, and obviously we will be talking about the treatment management and assessment plan for the bipolar disorder. So, moving forward toward our lecture, when we are talking about the substance or medication induced any kind of psychological disorder, you have to understand that it should have two basic components to be covered. The first thing is the particular substance or the medication you are concerned about must have a literature or research to justify that it's intoxication or withdrawal or any kind of long-term exposure to that substance will create those particular concerned symptoms. All right. And the second thing is that that particular substance or induce must be capable enough to produce those particular symptoms you are being very concerned about. All right. So when we are talking about the bipolar related disorder and especially medication and substance induced bipolar disorder, you have to understood regarding the DSM criteria that a prominent disturbance in the mood should be present that should dominate the clinical picture. All right, including the obviously the basic framework of the bipolar disorder, that is the irritable mood with or without some kind of depressed features. All right, and obviously the lack of interest or the failure in the activities or mostly in most of the activities in our daily life. So there should be some kind of evidence to prove that the substance you are being concerned about in case of bipolar and related disorder must have this kind of literature or research to prove that it's intoxication or long-term exposure, and even in case of withdrawal from that substance, can induce that particular kind of symptoms that are basic many feature of bipolar disorder. All right. So the second thing is that are being very concerned is that those particular substance you are talking about or any kind of medication you are talking about must be capable enough to produce those kind of symptoms that we have discussed in our previous criteria and even in our previous lecture for the bipolar disorder. All right. So the basic picture of disorder, especially the bipolar and related disorder, must be manuscript by that particular substance or even the medication. All right. Then it is not better explained by any other kind of psychological disorder. All right. Even it's not better explained by the bipolar and related disorders as well. It must be due to substance or medication induced bipolar related disorder. All right. So the symptoms should actually proceed with the onset of the substance or any kind of medication use. We will be talking about the substance particularly that will include the medication as well. All right. So over the substantial period of time when you are using some kind of substance, obviously that would incriminate in your body, in your metabolism, in your blood circulation, right? So the symptoms should proceed after the use of that particular substance for almost at least about a month. All right. So you have to take the history of the person in detail regarding the particular non-substance or even substance-induced issues to be ruled out. All right. You have to make sure to confirm the history of the person if they are taking any kind of medications regularly or using any kind of substance, like sometimes tobacco, sometimes cigarette. Sometimes there are certain vapes now available that have some kind of substances in them that can react as an hallucinogens. All right. So the disturbance should not occur exclusively during the period of the delirium. If it's about delirium, obviously that is regarding the degenerative disorder, right? So you have to rule it out as well, right? During that particular period of the delirium, there are certain medications for the delirium as well that have this kind of properties to induce for a certain period of time for the person to react in a better way, all right? So you have to rule it out. Then obviously the disturbance or the issue we are talking about have a clinical significant distress for the person as well as for the society and disturbing its normal areas of functioning in the daily life. All right. So here comes another case for students to understand, and even for the practitioners. That is the feature of the DSM is that it have actually manuscript and other category of disorders for every kind of disorder, that is other specified bipolar related or unspecified bipolar disorder. All right, it's been present in obviously at maximum disorders to be justified at other specified or unspecified disorders. So if you're talking about the other specified disorder, these kind of category actually applies to the presentation where actually the characteristic symptoms of the disorder that are causing the distress, or you can say the impairment in the individual's daily living functioning, are present. Symptoms are there, but actually they do not meet the full-fledged criteria of any kind of disorder, particularly if we are talking about the bipolar and related disorders. They do not actually meet the full-fledged criteria of any disorder there, all right? So other specified bipolar-related disorder would be used in situations where being a clinician or the professionals, we would suggest to communicate in a better way for the future presentation, all right? Where the presentation right now does not actually meet the full-fledged criteria of the bipolar and related disorder or any specific disorder, all right? So actually this would lead to the short-term presentation, and then reassessment would be required after a certain period of time, all right? For example, when we're talking about the hypomanic episode, we know the presentation should at least be present for like 4 days. But if the presentation of the episode for the hypomania is actually present for like 2 to 3 days, all right, with the some kind of major depressive episode lately. So obviously this does not actually have a full-fledged criteria there. So in that case, being a clinician, we would suggest that the episode of the hypomania do not actually overlap with the time, right? And they do not actually meet the full-fledged criteria for the disorder. So therefore, we would suggest about this kind of category, that is the other specified bipolar related disorder, all right? So here comes another kind of situation you can get, that is the hypomanic episode with insufficient symptoms or major depressive episodes, all right? Sometimes in case of hypomania, you can say the disorder or the problem is not fully being prepared in the person or the individual, actually. It's not being fully developed there to be presented in a full-fledged disorder way, right? So in that case, if an individual have a history of one or more depressive episodes, but they never actually full-fledged have a criteria to be mapped there, right? Or in case if a person have a history of mania or hypomania, but they actually do not have a very much category of presentation to be responded to be available to meet the full criteria, right? So in that case, I can say that they actually do not meet the full-fledged criteria of at least 4 consecutive days, or the symptoms I'm talking about of like at least the 5 symptoms to be present there are actually not 5, right? There are 2 to 3 symptoms other than the hypomania, right? And obviously, in that case, I would suggest that the presentation of the whole disorder is not being accomplished, right? So in that case, I can suggest that the hypomanic episode have an insufficient symptoms right now, all right? They're not sufficient enough to be named as hypomanic episode. All right. So in that case, I can say that the particular episode is being a bit insufficient, right? So in that case, I can name that case, or I can name that individual with the diagnosis of the other specified bipolar and related disorder, so that after a certain period of time, a particularly reassessment would be required. All right. So obviously, the management plan for that person and even the treatment plan for that person would be a bit different to be handled. All right. Here comes another situation where sometimes this kind of particular disorder would be justified. For example, a patient is being presenting hypomanic episode without the prior history of the major depressive episode. All right. So in that case, a patient is not having a history of the major depressive episode, or does not actually have met a full-fledged criteria for the major depressive episode in the entire history, or even not for the manic episode itself. All right. So in that case, I can say that this actually often occur in the individual when they are actually having a persistent depressive disorder. All right. In that case, episodes present themselves for a very short-term period, but over the long-term duration of around 2 to 3 years. All right. So in that case, presentation sometime of particularly about the disorder does not actually present itself in a comparatively complete disorder or specific disorder. All right. So in that case, we normally suggest to go with other specified bipolar related disorder. All right. There comes another situation where you can actually get confused that what should be the preferred diagnosis to be suggested. That is the short-term cyclothymia. In short-term cyclothymia, basically I can say that obviously the episodes for the hypomanic symptoms are not being met very well, right? But the multiple episodes of the depressive symptoms, actually they also do not meet the full-fledged criteria. So in that particular situation, sometimes often happens in the children and adolescents. In that case, the presentation for the disorder actually do not let to be covered in a full-fledged manner for the person. All right. They do not actually meet the criteria of any other psychotic disorder in that case, where I can say that this is that specific disorder. All right. So in case of short-term cyclothymia, that would be present for less than 24 months or the 2 years. All right. So in that case, cyclothymia have a short duration of around at least 2 years. That is the 24 months, right? But in that case, there would be, you can say, the basic presentation would be less than 24 months. All right. And no complete presentation of the mania or the depressive episode would be present. Right. So in that case, we suggest to go with the other specified and bipolar and related disorder. All right. Then comes unspecified bipolar and related disorder. In this category, basically, we would suggest that it's about the presentation of symptoms where basically the characteristics of the bipolar related disorder have been causing clinically significant distress or the impairment in an individual's life, but they actually do not meet the full-fledged criteria for any disorder that is being present or we discussed in the bipolar and related disorders. All right. Or even in the DSM. All right. So in that case, in that situation, we, being a professional, can choose not to specify the reason that the criteria are not being met for the specific related disorder and include the presentation, which is basically insufficient for the information to make more specific diagnosis. All right. For example, in case of OPDs, in case of outpatient days, you can say that we do not have a very clinically informative history of the person to diagnose it properly. So in that case, we normally suggest not to specify the reason that the criteria are not being met, but also you have to be clear that the presentation of that disorder or the specific disorder is not sufficient enough to prove that that particular person have which kind of specific diagnosis. All right. So in that case, it's preferred to use unspecified bipolar related disorder. So here comes, we have discussed about the whole chapter of the bipolar and related disorders, and we justified it with their specifiers as well. So when we were talking about specifiers, it was a bit different than other disorders we talked about. For example, it included about the nature of the feature or the patterns present in the complaints for the person. That is with anxious distress or with the mixed features. It either the presentation of the symptoms is like hypomania and manic episode with the complex features, depressive episode with some kind of mixed features. All right, the rapid recycling. These are the particular specifiers that would be used in case of diagnosing the bipolar and related disorder. All right, the first specifier nature will be concerned about the features or the pattern present in the complaints of the person. Then comes, you have to specify about the symptoms presentation. Either they are in full remission, either they are in complete or the partial remission. All right. Then comes, you have to specify about the current severity of the problem. All right. Either you can say the severity index of the problem. Either it's mild, moderate, severe. So where does it actually lie? When we are talking now, I would be discussing about each specifier in detail to understand you in a better way that what are these specifiers and what they actually mean about. So when we are talking about anxious distress, the specifier talking about anxious distress is actually about those particular, at least those are the particular symptoms that are present in majority of the situations in case of mania, hypomania, and depression. For example, feeling keyed up or tense, all right, like being irritable all the time, being concerned about all the time without any particular stimulus. Then usually restless, then difficulty concentrating about something because of some kind of tension or worry, all right. They are basically having you can say on the go distress, all right. So in that case, they often feel fearful that something awful or something you can say a disastrous can happen, all right. So they actually have a kind of situation where they are actually being having anxiety issue as well, all right, along the distress. So individual normally may feel like lost interest in himself or herself, all right, because obviously that's a kind of distress, all right. Then come, if I'm talking about the severity of the problem, all right. So along with these particular symptoms, if any of the two symptoms are present, then the severity index will be too mild, all right. In case if the symptoms are three present in the individual, then it would be moderate. In case those particular symptoms are like 4 to 5 symptoms are present in the person, then it would be moderate to severe. But if in case if a person's features, all right, firstly I'm talking about the feature, then I'm talking about the severity, all right. When I'm talking about the feature, I have talked about the anxious distress. So these particular symptoms in case of anxious distress in the person, if 4 or more of the following symptoms are present, then it would be moderate to severe in case of bipolar related disorder. And if all those symptoms along with the psychomotor agitation is present, then the severity will be severe. All right. You can say sometimes a high level of anxiety in that case is associated with the suicidal risk, all right, or the long-term poor prognosis for the individual, and obviously the greater likelihood of treatment non-respondence. So in that case, it's being obviously suggested to make sure the individual is adherent to the treatment, right, especially the medication itself. So when I'm talking about the mixed features, it's actually about the current situation. All right. What is the current episode of the person, in case either it's bipolar 1 or either it's bipolar 2. All right. So in case if it's about the manic or the hypomanic episode with the mixed features, then a full criteria for the manic episode or the hypomanic episode has to be met, right? But with at least 3 of the following symptoms during the majority of the day of the recent episode should be present, all right? For example, prominent dysphoria or the disturbed mood, all right? Low mood, all right? Then diminished interest in the activities or the daily activities, all right? And that is observable by the others, all right? Psychomotor retardation nearly every day, all right? Fatigue, loss of energy, feeling worthless, and, you know, having an inappropriate feeling of the guilt, all right? Recurring thoughts of death. Now, these are particularly the physiological symptoms that we normally used to say about the depression, all right? So it's a manic or hypomanic episode, and other continuum of the problem, but with at least a bit mixed feature of the depression would lead it to be named as the mixed features. All right. So it has been mentioned that at least 3 of the following symptoms should be present to name it as with the mixed features. All right. First of all, you had to make sure that it's about what is the current episode, then you would name about the presentation features, then you would talk about the severity index. All right. So in case if it's about the current episode is about depression, so in that case, obviously a full criteria for the major depressive episode have been met, but at least along with 2 to 3 symptoms for the mania or the hypomania is being present in the individual during that particular episode. All right. That is an elevated mood, grandiosity, inflated self-esteem. He's being more talkative than usual, right? We normally have listened that depression have another form that is individual becomes more lively, they become more talkative, they become more social, all right? They have a flight of ideas, all right? Their thoughts are racing. That is because of this presentation of the disorder, all right? So it's being normally being a feature of the manic episode or the hypomanic episode. So in that case, 3 of the following symptoms should be present in the depressive episode itself. So in that case, it would also be named with the mixed features. All right. If a client is having a decreased need for sleep, increased involvement in the activities that have the high potential for the pain, or even you can say the uh, foolish outcomes, all right? So in that case, overall, the 3 symptoms from each case would be present in that particular situation or the current episode from another continuum. Then we would suggest it to be mixed features, all right? Then comes melancholic features. All right. Then comes the rapid cycling. All right. In that case, rapid cycling actually means the presence of at least 4 mood episodes in the last 12 months. All right. With any kind of full-fledged criteria for the mania, hypomania, or the major depressive episode. All right. But you can say for at least just 2 months. Okay. So basically, I can say the essential, or you can say the basic concept of the rapid recycling bipolar disorder is the occurrence of at least 4 major episodes during the previous 12 months, all right, with a combination and order. Okay, they can happen in any time, like just a manic episode or just a hypomanic episode, or even with the depressive episode that can happen but either by the full remission or either by the episode of opposite polarity. It can happen, but with the continuum of 12 months. All right. So in that case, it would be suggested to be rapid cycling pattern. All right. They are not different from any other continuum. So it's like being in a vicious cycle where it happens to be along the side. All right. Then comes the melancholic. In case of melancholic features, basically I can say the problem is present during the most severe period of the current episode. All right. Where actually the problem appears to be loss of pleasure in almost all the activities. All right. Lack of reactivity to the usually pleasurable stimulus. All right. They do not feel better. They temporarily just, kind of like insensitive toward that particular stimulus. All right. So in that case, it's like melancholic, which actually means insensitive, right? Okay, then there comes another thing about the melancholic features, that are those particular symptoms I'm going to talk about. At least 3 of them would be present. That is distinct quality of depressed mood, by the profound despondency, despair, or morosance. But you can say it's like an empty mood, insensitive expression. All right. Then depression that is regularly worse in the morning. All right. Early morning awakening, like at least 2 to 3 hours before the usual awakening cycle. All right. Psychomotor agitation or retardation, significant anorexia or weight loss, excessive inappropriate guilt. It normally happens in the female because it's you can say a bit more feature that is related to the intraneous stimulus. All right, intraneous factors. All right, so it normally happens more often towards the female. All right, this feature actually applies when the present episode is at a very severe stage. All right, and there is a near complete absence of the spacity of the pleasure. We can say diminution. All right. So in that case, it's normally being suggested to be called as melancholic feature. That is the peak point for the depressant, or you can say the guilt feature to be presented. Then comes with the atypical feature. If in case I'm talking about the manic episode or the depressive episode or the hypomanic episode, and I'm talking about the atypical feature, then it actually means where these particular feature predominates during the majority of days of the current or more recent major depressive episode. Atypical would apply to the major depressive episode, all right, where actually typically it would not be the basic presentation for the major depressive episode, but it would happen predominantly during the majority of the days, where patient or the person would complain having a mood reactivity. That is, mood brightens in response to the positive stimulus or a positive events. Hyper reactivity towards that stimulus. Then 2 or more of the following features would be present. That is a significant weight gain or increase in the appetite. Right? This is not the basic framework for the major depressive episode, right? So in that case, it would be a very atypical presentation. So that's why it would be named as atypical feature. All right. Hypersomnia, increased need of sleep. Leaden paralysis, that is heavy or leading paralysis in arms or legs. All right. That normally happens because of their insensitivity. All right. Then a long-standing pattern of interpersonal rejection sensitivity, not limited to the episode, but that result in their significant social and occupational impairment. All right. That is obviously not a basic typical presentation of the major depressive episode, but during that particular episode of the major depression, patient would be complaining these particular symptoms sometimes. So you have to understand that if it's happening in the majority of the days during that particular episode, then it would be named as the atypical feature. All right. Then you have to understand that there is a difference in the leaden paralysis and the catatonia. In case of catatonia, I can say that it's about being rigidity toward that particular position. All right. But in case of leaden paralysis, that is basically our heavy feeling in the arms or legs. Right. They just feel like I can feel my legs. I can sense your touch towards my legs or towards my arms, but I'm not able enough to actually move it like that. I can't twerk my legs. I can't twitch my toes. All right. So in that case, it would be latent paralysis, not the catatonia. All right. Then comes the psychotic features. When I'm talking about the psychotic features of these particular episodes, it actually means about the particular presentation of psychosis that includes the delusions or the hallucinations that would be present for a big period of time in any of the episodes. All right. So basically, when there are a basic feature presentation of the psychotic episode, you have to specify if it's mood congruent or it's mood incongruent. In case, if I'm talking about the mood congruent psychotic features, then it actually means where during the manic episode, obviously, we know we had studied that it would include the delusion of grandiosity and sometimes about different other delusions itself. So, along with the hallucination, it's being consistent with the typical manic theme of grandiosity, all right, invulnerability, irritability, psychomotor agitation or retardation. So that would be mood congruent, or you can say the basic presentation of the manic episode along the psychotic features. All right. Then comes the mood incongruent psychotic feature. In that case, the content of delusion is being very inconsistent with the episode theme. All right. As we discussed previously, then the content is the mixture of um, mood incongruent and mood congruent theme. All right. You can say that in case of mood incongruent psychotic features, basically the current episode theme does not match with that particular delusions or the hallucinations. All right. If it's the major depressive episode, but the basic theme of the person does not match with that particular psychotic feature. All right. It would basically be suggested by your clinical assessment. All right. We had talked about the catatonia. Then comes the peripartum onset. In case when I'm talking about the peripartum onset, they are basically where I can say the full criteria are not currently being met during the mood episode, but it normally occurs during the pregnancy of like 4 weeks following the delivery, or I can say in the peak period of pregnancy, where normally the females would have a peripartum onset during their 7 to 8 months of the pregnancy. All right. So in that case, they would have a very incomplete presentation of the mood episode, but they would have a very recent mania or hypomanic episode or the depressive episode. You have to be sure about it. If it's bipolar 1 or bipolar 2, then you would understand the most recent episode, then you would name about the current feature, that is the peripartum onset. Then you would suggest about the management plan. Sometimes peripartum onset can have either with or without. Sometimes it presents itself with the psychotic features as well. All right. Infanticide is most often associated with the postpartum psychotic episodes. Right. But with the command hallucinations to kill the infant or delusion that the child is possessed, or the psychotic symptoms can also occur in severe postpartum mood episode where there is no specific delusions or the hallucinations or even this depressive symptom, but they would have a basic psychotic feature or having a peripartum onset with the postpartum episode. All right. Peripartum means during that particular time of the pregnancy of the 9 months to develop the baby in the womb. All right. And after that comes the postpartum. All right. The basic episode would begin in the postpartum, where they would have a different kind of symptoms that normally command hallucination that would come with the delusions of the child being possessed, that normally comes with the delusion that this child is not mine. All right. So it depends. It's being reported that around ladies with the recent pregnancies, 30 to 50% of the individuals or the females have a postpartum episodes, which is normally being long-term implication. All right. Then comes the seasonal pattern. When we are talking about the seasonal pattern, you have to understand that it implies to the lifetime pattern of the mood. All right. The essential feature or the content as the regular seasonal pattern of at least one type of episode, right, in that particular season. And they would not follow this pattern. All right. For example, if an individual have a seasonal mania, right, she would say that I become, the irritable or psychomotor agitation have, the on the way to go in my winter season. All right. But his or her depression do not have any regular season to occur. All right. Only one basic episode would have a season. Okay. There are regular temporal relationship between the onset of their a particular episode and the particular time is being present. Okay. And their full remission also occur at the particular characteristic time of the year. All right. For example, it's being in the researches that the depression disappears in the spring, right? Mania comes normally in the winter. Depression normally appears more often in case of early winter season or in case of high heat seasons. All right. During the peak summer. All right. So you would have to determine their peak episode, their seasonal episode, and define about the things we discussed, and then non-seasonal episodes of that polarity to be sure for like the 2 previous years. All right, you have to take at least the 2-year history to determine their seasonal pattern first. All right. Okay. We had talked about the basic classifiers, about the features. We had talked about the severity index. We have now going to talk about the remissions. All right. In case of partial remission, it would actually mean that the symptoms of the previous manic episode, all right, immediate previous manic episode are present, but the full criteria are not met. All right. There's been a period of at least 2 months without any significant symptom of that particular episode following the end of such episode. All right. I can say that it's been like dissolving the episode. The whole episode is not being dissolved, but the core features or the presentation of the complaints are present there for at least 2 months. All right. Then comes the full remission. During the full remission, during the past 2 months, I can say no significant sign or the symptoms of the symptoms are present. The whole problem has been completely dissolved. The whole episode has been completely dissolved and exterminated from the individual. All right. Then comes specify your severity. We have discussed about the specifiers. All right. Now, previously the students was asking me that if I can revise how to write the basic diagnosis of the bipolar and related disorder. All right, I'm gonna revise it for you guys. Here comes the coding procedure for that. First of all, you would have to write down the particular code of that particular disorder. For example, it's the complete code for the bipolar II. It's the standard code for the bipolar II. All right, it's being mentioned here. Okay. Then you have to write it down the name of the disorder. Then you would suggest about the current episode, if it's manic, hypomanic, or depressive. Then you would suggest about the severity index of that episode according to the continuum that we had talked in each and every feature. All right. Then with particular feature we have talked about, if it's either atypical feature, if either it's melancholic, if either it's with psychotic features, what are the basic presentations of the features along with that particular episode. You have to mention that as well. All right. Or you have to mention if it's in the partial remission where the symptoms are not completely resolved from the last 2 months, or if it's full remission where the symptoms have been completely exterminated for the person for this episode. All right. So this would be the basic presentation to write down the diagnosis for the bipolar and related disorders. Now, moving forward towards our differential diagnosis for the bipolar related disorders. Whenever you are diagnosing bipolar and related disorder, you have to make sure to differentiate the individual. If either it's from the generalized anxiety disorder, you have to make sure to rule out the depressive disorder, then the post-traumatic stress disorder, psychotic disorders, substance use intoxication, particularly in case of substance-induced bipolar-related disorder as well. Then impulse control disorder, especially in adolescents and children's. Then eating disorders, specifically about the adolescents. So these are the three categories you have to make sure to exterminate or differentiate from your complete diagnosis first. All right. Then what are the theoretical grounds when we are talking about bipolar disorder? What are the basic theories behind the bipolar related disorder whenever we are going to conceptualize the bipolar related disorders? Those are the particular theories that have some kind of means to study the bipolar and related disorder. First come the behavior approach system dysregulation theory. Normally, we used to call it BAS. It says that integrated psychosocial and the biological factors contribute towards developing certain kinds of behavioral issues along with our psychosocial problems, where a person would have a psychological issues later on. All right. Or I can say basically an individual have a predominantly um, factors biologically inherited or developed over the period of time, and then it would develop a psychological issues in the person that would infiltrate with their social relationships. All right. Then comes another theory, that is the cognitive behavioral theory. In that case, as we all know, it's normally being used in the treatment management of the bipolar related disorders as well. Then comes the interacting cognitive subsystem model. Another one is about behavioral activation and inhibition system. It's normally being used for the management of the bipolar related disorders. So what is the basic evaluation you would have to be suggested to move forward toward diagnosing a person with a bipolar related disorder? First of all, for the medical assessment, we normally made sure that it's not being caused by the hyperthyroidism. So for that reason, individuals are normally suggested by the general physicians to move forward toward the thyroid functioning test, urine analysis, and for the purpose of understanding that it's not about the neural issues or the neurotransmitter problems, they would suggest neural exams that include the noradrenaline, serotonin, and the dopamine. All right. Or I can say these are the three neurotransmitters that are being responsible for causing a problem that will lead towards the bipolar and related disorders. Then comes what are the assessments that would be suggestible for the person to diagnose an individual with the bipolar related disorders. All right, that would depend obviously on the duration of the problem, onset of the episodes, and as well as on the prior history of the problem. But as like that, we have to make sure about our assessment that what is the problem at the very peak point right now to make the diagnosis being very confirmed. So that would include the Altman self-rating mania scale, internal state scale, young mania rating scale, Beck Raffleson mania rating scale, then schedule for the affective disorders and the schizophrenia version Manic subscale. All those assessment plans have their different use and administrations, and obviously different scoring systems as well. But I would suggest that these are those particular assessments that would be very beneficial for the students to learn about diagnosing the individual with the bipolar and related disorders. Then what are the treatment management for the bipolar related disorders? When we are talking about the treatment management for the psychopharmacology, normally psychostimulants are used for the purpose of the bipolar related disorder. What are the psychostimulants? That would include normally the barbiturates, antipsychotics, especially quetiapines and olanzapine. Then benzodiazepines are also used, especially the clozapam and the diazepam. Then haloperidol and typical antipsychotic is also being used, but it has a very potential risk for the EPS. All right. Then comes lithium. That is normally being very much practiced in case of bipolar related disorder, especially for the case of manic episode. But in case if the lady is being pregnant or the patient is being pregnant, then you have to quit this kind of medication, especially the lithium. Then comes the anti-epileptics. Normally, valproic acid, lamotrigine, levetiracetam are also being used. Risperidone, ziprasidone, and aripiprazoles are also recommended over the period of time, but that are just for the reason to stabilize the mood for the person. All right. For the psych care, being a psychologist, our clinical needs and practices are a bit different as compared to other medical fields. So, what are the therapies I can recommend for the person to learn, especially for the care management for the bipolar related disorders? That would include the cognitive behavioral therapy, interpersonal therapy, social rhythm therapy, family focused group therapy, and even the family therapy, mindfulness interventions, dialectic behavioral therapies, group psychotherapy, self-help programs are also being available recently. Then the play therapy. In case if the patient is not very much concerned about the cognitive behavioral therapy, or you can say they are not very compromising about it, then in case you can use play therapy as well in case of bipolar related disorder if the client is well educated, or you can say he's very much being sensitive towards the book, then you have to make sure to give them some kind of neutral positive skills book to read them, to evaluate them. All right. You can use play therapy in a very vast domain in case of bipolar related disorders. All right. Here is the case presentation I made sure to share with you guys. That is, here comes a female that is a 34 years old, and she presented with the complaints of the physical and verbal aggression from the last 1 year with the irritable behavior, social and emotional withdrawal, suspiciousness, or you can say a delusion, weeping spells, irrelevant talk, or very much talkative on the go, all right, restlessness, irrelevant talk, regret feeling from the last 1 year, all right. So for the case of the evaluation, we made sure about the clinical interview to collect the history. Then we made sure about the symptom assessment checklist. Spotify was used. Then the Bender's Gestalt test, house, 3-person, standard progressive matrices, Young Mania rating scale was also used for diagnostic reasons. All right. So we would directly move towards the case formulation of this report to understand it in a very short term. Her predisposing factors were found that neglected and harsh marital relationship, her emotional and she faced emotional and physical abuse, lack of decision-making skills in herself, vulnerable towards the harm, and lack of the social support led toward the predisposing factors. Then the precipitating factors involved the marital conflict, hyperactive responses. She had a non-compliance with the family, postpartum depression after her abortion. All right. These were the factors that become contributing towards the presenting complaints that lead to this problem. All right. We started about. But her perpetuating factors, the factors that remain there or that maintain the problems, include the previous diagnosis of the depression during her postpartum period of after the abortion, then the lack of social support in the form of the family, especially from her mother, criticism from her family, and poor coping method led to her long-term reason for this problem to develop over the period of time. All right. And that become this kind of presenting complaint later in her life. All right. So the basic conceptualization for this kind of case is basically there the difference of time and duration of the mania that requires for the bipolar disorder and the hypomanic episode, obviously from the bipolar II disorder. All right. So in such cases, there is a history of more than 2 to 3 months of the episode. So in that case, basically you can say the factors behind are basically involved in these kinds of problems, and you have to make sure to actually eliminate those factors, to work on those factors. So the basic diagnosis what made bipolar 1 disorder, all right, because the episode for like most of one of the year, all right, with most recent manic episode with the mixed features, because here comes the restlessness, all right, regret feelings, weeping spells, social and emotional withdrawals. These were also the very much symptoms regarding the depression. So it led towards the specifier of the mixed features. All right. And with the V code and Z code, that is the due to the spouse violence and non-adherence to the medication. All right. For the management plan, I can suggest that those were the particular techniques we used over the period of time for her to resolve her issue in a very brief manner. That included the relaxation techniques, obviously, psychoeducation towards the family, towards her own self, then engagement in different group tasks to involve her, or for the rapport building as well, because those actually involve a very long term um, management towards such kind of patients. Social skills training, then cognitive restructuring, then self management, positive energy work strategies, distraction techniques, mood monitoring chart for her long term outcomes. All right. And we even gave her the therapeutic blueprints to involve. All right. So we discussed the case, and I made sure that you guys have